reflexes will open up the arterial resistance and you'll begin to relocate blood into the skin. So cardiovascular drift is really a condition of the peripheral circulation in which heat stress tends to dislocate blood out of the central circulation during exercise, and it gets stuck, quote unquote, in the skin. This was the topic of my master's thesis, and I was the first to show that if all you did was restore the amount of airflow, so these are people working at 60% on a stationary bike, and in the case of no fan, I treated them just like you normally would in a laboratory environment, no airflow, and they drifted by 20 beats per minute in a slightly more than 1 hour period. All I had to do was turn a fan on them, and I didn't turn the fan on super high. I calculated what speed, for this level of oxygen consumption, at what speed would they move through still air. I turn a fan on at that speed. Notice it eliminates, they have about a 5 beat per minute drift, so I eliminated over 80% of the cardiovascular drift simply by directing airflow across their skin. To test the idea that it's blood flow into the flabby circulation of the skin that's doing it, I directly measured skin blood flow, and you find in the stabilized state, they double resting blood flow is about 5. They double their resting blood flow and hold it constant. In the case where they're progressively destabilizing, it's because more and more blood is winding up in the skin. Yes?
Are you measuring this in the venules of the forearm?
Very hard to do. No. At the time, that was not possible, and it's still very doubtful if we're able to measure that. But because the venules are floppity in the skin circulation, the amount of blood flowing into the swamp is highly proportional to the amount that gets trapped in there. It's a very good question. Oh, and just to show you how many friends I lost during this thesis, I recruited all my buddies in grad school, and they really didn't like me at the end of this protocol. So this is the one where they're working hard with no airflow. And again, if a resting mean arterial pressure is around 95, it ought to go to about 100 and more, as it does. Notice that in the condition where air blows across the skin and you can keep the skin taut. Oh, Drew, this is a soccer, I don't know if you're a halfback, but when I was a halfback, I loved days that are cold. Run and run and run and run and run, and the second half was no different than the first half. On hot days, this problem occurs, and pretty soon not only are you unable to come up with perfusing pressure to keep your muscles happy, you also get pretty damn stupid. You start to make mistakes because you're not really perfusing the brain in the manner it needs to be. If anyone's ever had that experience. This last picture is just to show you, these are 2 big marathons. One is in Chicago, one is in Paris, where you have thousands of people running the marathon. And it's showing you that on days which are hot, just to show that this cardiovascular drift thing really does affect human performance. On warm days, endurance performance suffers. You can't come out with the same level of performance on a hot day as, and so if you look here, on Chicago 07, the hot day, there's 2 curves because one of these curves is elites and one of these is the regular people. They just want to make sure that everybody was affected in the same way. When you get hot, you become slower. On the Chicago day, when you're looking at 42, Una was telling me it was 42 degrees this morning versus 77. The 77-degree day added 35 minutes to marathon times. So it's very significant. If you're trying to PR in the marathon, pick a cool place. Run in Oregon or Washington. Do not do the Death Valley Marathon if you're hoping to PR. You can read that on your own. Any questions? Hey, by the way, I'm sure you guys are feeling some pressure just like I am with the redone quarter. Many of you gave me ideas about how to redesign our class. Jaron did, Sarah did. Many ideas came in, and I used every one of them to try to figure out what to do. If people have objections or other creative ideas, email them to me, because I really will listen. I think I came up with the best muddle through the middle. But if you have another idea, okay, this lecture is naturally a little bit short, and so I think we're going to be okay. This is the last of our 4 lectures on cardiovascular adaptations to exercise, and this one is specifically about training effects. And so to help you remember it, I've made a little mnemonic poem. Bigger hearts, more blood, less stress, and vessels bud. Right? These are the 4 primary changes that we're going to go through that happen as people chronically do. It's usually endurance training. Several of you asked about, I think Jayinder asked me about, is there an adaptation with weight training? And it's not this. So, as we look through this, I want you to see the overall pattern, and you can look at this later, this figure. But the main take-home point is, if you have a little pony that to pull a cart is using 80% of its pulling capacity, you got to keep banging the quirt down on the little pony's withers to keep it going. Hey, get it going. Hey, 80% is a lot. If you take that pony away and swap it out for a pony that's 50% bigger, so now the same cart is only demanding about 40% of its abilities, then you can put the quirt in your pocket. Are you with me? That analogy is what's happening in cardiovascular adaptation. If you give it a little time, the system rebuilds itself so that you have more heart and more blood volume stretching the heart. And so you go from your normal cardiac output curve, Yoke, who's asking about this, to a hyper-effective curve. More heart, more blood volume. The same will happen with your venous return curve. If you retain more fluid volume in the circulation, it's going to put those venules under stretch, even at rest. And so an increased blood volume will take you to a supernormal level of venous return. Once you've done that, that's the bigger pony. So if you've got bigger hearts and more blood, you don't need to use epinephrine as much. That's the less stress. You no longer need to whip the heart and circulatory system with sympathetic drive. So you'll see the pattern as we go through. So first topic, bigger hearts. There's a heart. Let's cut it through right there in the left ventricle. Flip it so you can look down. There's the ventricular cavity or blood hole. And then there's the ventricular wall. Let's do pathology first, because we're talking about afterload in office hour this morning. Increased afterload does a very peculiar kind of unnatural hypertrophy. So the most common reason to have an increased afterload, you could have a scarred aortic valve, but by far the most common is hypertension that's not been treated. And what happens is the heart becomes adapted to pump really high pressure, tiny little stroke volumes, which means it does a hypertrophy where the wall thickens, and the wall thickens con centro. Vamos con centro con los músculos de cardia, de corazón. So it hypertrophies inward, and this is called concentric hypertrophy. It's pathological. If you see concentric hypertrophy, for instance, I have high blood pressure. One thing, in fact, I was going to ask my doc if she wants to do it. If I were to get an echocardiogram and it showed that my ventricular cavity had shrunk, that would be a really good way to indicate that over the last year my hypertensive control was not good enough. Does that make sense? Because this is a response to chronically elevated afterload, particularly diastolic pressure. Okay, let's leave pathology. You guys don't have to think about that for 40 years. Let's go over to this side. If you do endurance training, you get almost the opposite response. Remember, the endurance athlete is loading their heart with a large volume of blood, and the pressure is only going up by 10%. And so what you get is, notice the blood hole gets bigger, and the ventricular wall is slightly bigger here. It's in perfect proportion to how much bigger the hole is. So the primary change in size has to do with the ventricular cavity getting larger to accept greater venous returns. And then an increase in cardiac myofibrils inside the myocytes to be able to manage that amount of extra fluid. Perfect little thing. In weight training, Jayender, was it you who asked me? I thought it was. In weightlifting, because you only have the increased resistance to flow during the lifts, and the lifts are only 20% of the total time you're in the gym, you actually have a rather small effect. The venous return is not increased, and so the blood hole does not generally increase. The left ventricular cavity stays the same size, and there is a very slight thickening of the walls relative to the blood hole to manage the very high pressures. You know, if you're doing a squat at maximum, you probably have systolic pressures above 200, 250. So the wall thickens to deal with that very short-term increase in pressure. There is no evidence that this is bad for the heart. This is bad for the heart. There's no evidence that that's a problem. Is that okay? All right, so bigger hearts. And this is a real deal. You can measure it. Those are two identical twins from Germany back in the 50s, is why it's black and white. This is Otto, and this is Ewald. This is shortly after they graduated from high school. They've been doing athletic training for about 5 years, since freshman. Can anyone want to guess their sports? They don't do the same sport. Guesses? Ewald does some form of resistance training. He's actually an Olympic. Olympic weightlifting is popular in Germany. So he's an Olympic weightlifter. What does Otto do? He's a runner. Okay. So, and I think, so far I haven't told you anything that you didn't know. Lifting heavy things causes an increase in mass, right? But the interesting thing in a heart lecture is to look at their hearts, right? One way to express heart size is per unit of lean tissue. And there's a very constant ratio that you have about 10 milliliters of heart volume for every kilogram of lean body mass. So how interesting that Ewald, who is bigger by, it's a lot of kilos, Ewald is bigger by, you can't see the weights up here, I'm trying to find the weights. He's got something like 40 pounds more lean mass on him. And yet his heart is exactly the same size per piece of tissue as a regular person. So his heart is only bigger to the extent that he has become bigger. What do you think is going to happen over, oh, you can see it. Otto, he's expanded his heart more in proportion, so in other words, Ewald has increased his heart size in perfect proportion to his resting lean mass, which is what he has to feed. Otto, on the other hand, is going to have increased his heart to the total mitochondrial volume, the potential for oxygen consumption. And so what you find is little scrawny Otto has about 2 times as much heart as he ought to have for his little frame. That make sense? Reasonably convincing data? You get bigger hearts. Now, on to more blood. Any questions about that? So, next line of the poem is more blood. And someone was asking me about this today as well in office hour. We talked about the hematocrit, or packed cell volume. And in regular folks, about 40 to 45% of the total volume, if this is 100% from there to there, somewhere between 40% is filled with cellular constituents, mostly red blood cells. Now with training at sea level does not expand the red cell mass. What it expands is the plasma. And this happens very quickly and a very large amount. So here I've a 12% increase in the plasma volume. You've gone from, the red blood cell mass is the same. So what's going to happen to the hematocrit here? It's actually going to, the term is hemodilution. The hemos are going to be diluted by this greater volume. Can anyone tell me why, what do we do with plasma? What does plasma do inside the circulation?
Does it decrease resistance? Increase resistance?
So we have a lower resistance to flow, the viscosity of this blood. This is sort of like an adaptation to a fast-moving circulation. The blood can move forward more easily, okay? It's providing stretch for both the atria and the venules. What do we carry heat with? The liquid fraction of the blood. And then how do we transport fatty acids again? Albumin is a plasma protein that's dissolved in this. So this one step is like a triple hit for enhanced cardiovascular function, fat transport, heat transport, etc. We'll talk about the how of this. Inga was asking me again during office hour, how is it that we shift to a retention of fluids? And it's connected to the fact that after a good workout, our urine flow is very concentrated and very minimal. Almost as though we were retaining fluid in the post-exercise period. That's a preview. That make sense? Oh, good for me. I think we have time to look at this. This is Vic Convertino's work. He got his PhD here back in the 80s, then went to work for NASA for about 25 years. He just recently retired and was given a medal for his work. This is his PhD. And what he did is he just brought people into our lab, and they worked out for it was a long workout. It was 2 hours a day. But it was only about 50% VO2 max. It was really quite light. Heart rate's around 120. And notice, here's the red blood cell volume. During the 8 days of training, notice there is no change in the red cell mass. Notice the plasma volume rapidly goes up. And the difference here is, let's see, 35, it's a half a liter at least. That's in 8 days, guys. That's a week and 1 day. That much more blood volume in 1 week. You only have 10 of these total. So it's 10% increase in blood volume in 1 week. By the end of the month, quite easy to have 2 of these, a full liter of additional blood. So the more blood thing is very rapid and very important, and I will bring it home to the cardiovascular lectures that we finished. This is a very cool experiment where a patient is just laying on a table. A cardiac transfusion of blood equal to 20% of the blood volume. So that's 1 liter. So the person's just laying on a table, and you infuse a bunch of blood into them. Beyond, they're not bleeding. You're not doing this for medical reasons. You're adding on top of what they have. Notice that the additional stretch on their right atrial pressure drives them up to a resting cardiac. Why do I have a resting cardiac output of 12 liters a minute? It's about 250 more than I need. Stretch on the atria, right? And then notice what's happened to their venous return curve has gone off the chart. The additional blood volume out in the periphery is stretching those tiny little venules, which are elastic, and creating a much higher drive-in pressure for venous return. Remember we said natural drive-in pressure for venous return is about 7. It's more than doubled. That make sense? So picture when you say, okay, bigger hearts, more blood. The more blood is huge in enhancing cardiac output, enhancing venous return. So now we're in the situation where we have switched out the little pony who is struggling with the cart, and we've brought in a big pony. Do we need to whip this pony as hard? I mean, one way to say it is, do you want to walk around over perfusing every organ in your body by 250%? No. That's the hardest line in the poem, is less stress. So bigger hearts, more blood. Those two changes lead you to be able to turn down the sympathetic nervous system tremendously. Remember we talked about how resting people have lower heart rates? That's parasympathetic. You actually have to turn up the inhibitory tone, the parasympathetic tone of the heart. Athletes' hearts need to be restrained at rest. They're too good. And so we'll see less stress is our next step in the poem. This is norepinephrine, an epinephrine response to a single, these people were doing interval training. And at the end of each week, they did the most hideous workload you could give to someone, which is a 5-minute exercise bout set at their VO2 max. So you do it, you warm up a little, and then go ready, set, go, and the workload dropped on you as VO2 max. It's nasty. Notice the first time they do that, you get these maximal, oh look, here's heart rate, you guys speak heart rate. You get heart rates of 200. Well, that's maximal in a grad student. All right? And that's associated with the highest levels of norepinephrine and epinephrine you're going to get, short of breaking their femur or shooting them. The highest levels of epinephrine we make in a day are when we push hard in exercise. Now notice, let's just go out 3 weeks later. Same workload after a week of training, 2 weeks training, 3 weeks of training. Epinephrine levels have been cut to 40% of what they were. Norepinephrine are cut in half. And the heart rate response is now a very reasonable 165, not maximal. They have bigger hearts and more blood, and therefore there is less stress to do the same work. Does that make sense? You no longer need the amount of sympathetic drive once you develop these structurally bigger circulatory abilities. Mary?
Is this maintained even after like months and months of training? This lower resting heart rate?
It will go away when they stop training. When they get injured, it will go away over, I've seen that a couple of times. Call it 3 weeks to lose the neural adaptation. Even though there may be parts of the structural adaptation still hanging around, the neural adaptation reverses a little faster. Okay. You may ignore that slide, that second figure here. You can ignore the second one. What it's showing you is that, strangely, if you actually measure the size of the adrenal medulla, the adrenal medulla with training actually gets bigger. So you have more epinephrine on tap, but you don't use as much of it for each workload. So this is I had to draw this to give you a sense of what's happening. Once you adapt the system, at any given workload, you need less total hormone to get the job done. We just saw that graph. What's fascinating is, remember, the maximums have now changed. What used to be maximal, what the person could not go beyond before, has changed with training, so now it's up here. And if you push the person into their new maximum, they will actually degranulate their enlarged adrenal medulla and release more epinephrine than ever before. So it's a weird kind of, you get whatever you want. As long as the workload is within the capacities you previously had, it's, I shouldn't say no sweat, it's no hormone. You just don't need it. If you go to the new higher level that you've never tolerated before, your adrenal medulla is there to back you up and release epinephrine at a higher level than ever before. So it's kind of, it's the best of all worlds. You get whatever you need. All right? We only have one more line in the poem. So to summarize where we've gone so far, you can almost look at this on your own. It's showing you the changes. Someone was asking me about this earlier. I forget who it was. In office hour, about here's cardiac output. Notice that the amount of cardiac output you need to support each workload doesn't change. What changes is your peak cardiac output. Here going from 18 or 19 up to 22. Blood pressure response is actually lower. You're actually able to support work at a lower systolic and mean arterial pressure. Total peripheral resistance, you can elaborate more. Vasodilatory metabolites, now that you're working harder, you actually drop the pressure lower and fill it with more cardiac output, so you actually can do more work. So that kind of, and the VO2 max goes up. You can look at that on your own, it's easy to figure out. What's the last line of the poem? and vessel's bud. And this is really interesting because this has some potential for clinical work. So I think we've seen these fibers, I've used them as nice examples before. What I want to point out is that when, let's say this, I think we were saying, imagining that this one here is a 2X fiber, right? Because it seems to have a paucity, a lack of capillary investiture, implying it don't care about oxygen, implying it probably uses cytosolic lactate production for its energy. Make sense? These that are so red, that is certainly a 2. I mean, sorry, a 1. That's a 1. So if you then were to do exercise that actually recruited this for aerobic exercise and you made it keep working, you're like doing 800 meter repeats. And so you're turning this one on because you're running so hard, but you're actually forcing it to hang for 2 minutes. Well, it's going to begin to undergo some surface changes. And we didn't know, again, when I was a grad student, how more capillaries, this is an old study from when I was in grad school showing that after about 6 months of training, this takes a long time to build new blood vessels, as you might imagine. But if you look at people who've been training for about 6 months, you generally find something like a 25 to 50% increase in the, I did cross-section here, in the capillary density within the muscle. We didn't know how that was happening. We now know that the lining of the capillaries themselves is able to release a paracrine factor called the vascular endothelial growth factor. And the things that cause this are high levels of metabolite, that sounds like working muscle, heat, acid, low pH, well, doesn't that all sound like work? Oh, and shear force, turbulent flow inside the capillary. So all of these things stimulate the capillary wall, and they say, you know, we could really stand to have more tubes here. And then in the presence of VEGF elaborated by these cells and acting on these cells, you'll begin to either sprout, vessels bud, literally, you bud out new vessels, or you can actually drop a septum within a single capillary, and then it branches off in 2 directions. That has the completely unpronounceable name intussusception, which is a medical term that you don't need to know. Is that all okay? So, just to show you why that is such a big deal to know about this, tumors grow and tend to elaborate their own blood supply. They literally steal, if you have a cancer growing. It is literally creating its own blood supply and stealing from the other organs. Can you think about how it might be doing that? VEGF? What if you could create a VEGF blocker? And more precisely, give it in a dose that anything that was elaborating VEGF at 200 times or 2 times the normal level, you block it, and normal tissues be left alone. Wouldn't that be a great anti-cancer agent? There's about 500 studies going on right now about that. Now, on the other side of things, in older people, you may be aware that, as I mentioned, older people will sometimes rat out their heart from bad living. And a really common one is the coronary arteries, the little pencil-sized arteries that actually feed the heart muscle, become blocked. Right now, the cure for that is to take a sternotomy hammer and drive through the thing, spread the ribs, and stop the heart, and so very carefully bypass vessels. What if you could simply put a catheter in a vein or in an artery, drop into the heart, go to the place where the blockage is, and inject a bunch of this stuff? And then the person goes home and grows their own bypass? See how less traumatic and less expensive that would be? So this is very cool. This is why you may get tired. I get tired of teaching it to you. All of the cellular biology and intracellular signaling. One of the reasons why we're doing that to you is not simply to torture you. It's because there's so many elegant things you could do if we could sort of seize control of the reins of these adaptive processes. Right? Always the best way to start is to understand what nature is doing And then you can do intelligent things in terms of your intervention. So what nature does when we do chronic cardiovascular cardio training, makes bigger hearts, more blood, there is less stress, and vessels. Is that all right? We're all caught up. By way of your exam, just to help you, there's only going to be 2 questions on today's lecture. One of them is going to be about cardiovascular drift, and one of them is going to be about the adaptations that occur with aerobic training.